Hello everyone, welcome to Pediatrics and Neonatology. This video is about urinary tract infection or UTI in children. Now, prevalence of UTI varies with age. It is more common in infants and toddlers. In infancy, it is due to fecal flora which are present under the nappy, and in uncircumcised male, it is due to bacteria which colonize beneath the prepuce. In toddlers, strict toilet training, deliberate withholding, and infrequent voiding leads to urinary stasis, which can result in urinary tract infection. And beyond infancy, UTI is more common in girls because they have shorter urethral length. Now, UTI is caused by colonic flora which colonize the perineum under the nappy. These include Escherichia coli, Proteus, Klebsiella, Staphylococcus saprophyticus, and Enterococcus. Now, pathogenesis of UTI. UTI is an ascending infection. Fecal bacteria colonize the skin of perineum and ascend to the bladder via urethra and result in cystitis. Now, bacteria from cystitis ascend to the kidney and result in pyelonephritis. Rarely, UTI is caused by hematogenous spread. Now, in kidney, inflammatory and immunological response result in renal injury and scarring, and there is hypertension and renal insufficiency leading to chronic kidney disease. Now, risk factors for UTI. These include female gender, uncircumcised male, vesico-urethral reflux, especially grade 3, 4 or 5, forced toilet training, infrequent voiding, obstructive uropathy, urethral catheterization, and wiping perineum from back to front. Other factors include tight clothing, Escherichia infection, constipation, labial adhesion, neurogenic bladder, urogenital anomalies, sexual abuse, and immunodeficiencies. Next is classification of UTI. These include upper UTI, which include acute pyelonephritis, infection in renal parenchyma, acute lobar nephronia or nephritis, it means focal infection without leukefaction. Then renal abscess. This follow pyelonephritis or it may be secondary to primary bacteremia. Then there is perinephric abscess. It is pyelonephritis that dissects through the renal capsule or it may be due to contagious infection. And the last is xanthogranulomatous pyelonephritis. This is due to renal calculi obstruction plus Proteus or E. coli infection, and there is granulomatous inflammation in this case. Then there is lower UTI, which is cystitis, infection within the bladder. It may be acute hemorrhagic cystitis due to E. coli or adenovirus, which is a self-limiting illness in boys. Second type is eosinophilic cystitis, which is rare and it is due to exposure to an allergen. And third is interstitial cystitis, which is idiopathic and is common in adolescent girls. In this, there are mucosal bladder ulcers. Now, clinical manifestations are non-specific in infants and toddlers, but they become more specific as the child grows. Now, signs and symptoms of upper UTI include abdominal, back or flank pain, fever, anorexia, nausea, vomiting, lethargy, malaise, and occasionally diarrhea. In infants and young children, unexplained fever may be the only presenting symptoms. There may be poor feeding, irritability, jaundice, and weight loss. Now, in acute lobar nephronia, renal abscess, perinephric abscess, and xanthogranulomatous pyelonephritis, there may be renal mass. In lower UTI, that is cystitis, localized symptoms are present. These include lower abdominal or suprapubic pain, dysuria, urinary frequency, urgency, incontinence, and malodorous turbid urine, and there is no fever. In acute hemorrhagic cystitis and eosinophilic cystitis, above symptoms of cystitis are present along with hematuria. And in interstitial cystitis, there is urgency, frequency, dysuria, plus bladder or pelvic pain, which is typically relieved by voiding. Now, UTI is labeled as atypical when following criteria is present: urosepsis or positive blood culture, mass in the flank, abdomen or suprapubic region, poor urinary flow, increased serum creatinine, non-E. coli organism on urine culture, or poor response to appropriate antibiotics within 48 hours. Now, next is risk of UTI for girls and boys. For 2 to 24-month-old girls and boys, fever more than 102.2 degree Fahrenheit for 2 days in girls, and for 1 day in boys with no other cause, UTI should be considered in differential diagnosis. Now, how UTI case is evaluated? In history of present illness, ask about fever, urinary symptoms like dysuria, urgency, frequency, incontinence, withholding or hematuria. Ask about urine odor or abdominal, back or flank pain, oral tolerance and hydration status, and stooling history, that is constipation or withholding. In past medical history, ask about increased blood pressure, poor growth, previous UTI, vesicoureteral reflux, antenatally diagnosed renal abnormality, past history of urine withholding, circumcision status, history of recent or frequent bladder catheterization, history of recent or chronic constipation, and diaper use or toilet trained. On physical examination, note growth, height and weight, development, blood pressure, abdominal or flank pain, abdominal mass, evidence of urinary tract obstruction, and periorbital or extremity edema. Now, urine test should be done in case of typical UTI symptoms and unexplained fever, and this should be done before administration of antibiotics. Now, the methods of obtaining a urine sample. In toilet-trained children, clean voided midstream urine sample is required, and for this, clean the introitus with soap and water, and in uncircumcised male, prepuce should be retracted. Now, in non-toilet trained children, that is 2 to 24 months of age, urine sample is collected by transurethral catheterization or by suprapubic aspiration. Urine sample collected in a bag is a UTI exclusion method, that is, it is only reliable when it is negative. Now, urinalysis is a rapid screening test to make a presumptive diagnosis of UTI. These include biochemical dipstick urinalysis and microscopic sediment urinalysis. On dipstick test, positive nitrites with or without leukocyte esterase give presumptive diagnosis of UTI. But it is important to remember that nitrite test is false negative in early UTI or gram-negative pathogen infection, or if the bladder is emptied frequently, and it is false positive in periurethral or perineal normal flora or contaminated bacteria. Leukocyte esterase test is false negative in early UTI, and it is false positive in other febrile illnesses such as vaginitis. Now, on microscopic urinalysis, there is pyuria if there are more than 5 WBCs per high power field in centrified urine, or more than 10 WBCs by automatic counting in uncentrified urine. Pyuria may or may not suggest UTI. Microscopic hematuria is present in acute cystitis, and WBC casts are present in pyelonephritis. Urine culture is the gold standard test for UTI. Significant number of colony-forming units of a single pathogen should be cultured. Positive cultures of mixed uropathogens or non-pathogenic bacteria means contamination or normal flora. Prompt plating of urine specimen for culture is required. Otherwise, urine sample should be refrigerated. Now, on urine culture, UTI is labeled when there are more than 50,000 colony-forming units per ml of a single pathogen by transurethral catheterization or suprapubic aspiration sample. Most recent evidence suggests lower threshold, that is 10,000 colony-forming unit per ml for UTI, and many guidelines also suggest that any growth on suprapubic aspiration urine sample is abnormal. Now, in case of urine bag sample, UTI is presumed if following criteria are present. Patient is symptomatic, urinalysis is positive, and more than 100,000 colony-forming unit per ml of a single pathogen is present. If any of the above criteria are not present, then confirm UTI by catheterized sample. Now, asymptomatic bacteriuria is labeled when the child is asymptomatic with normal urinalysis, but the urine culture is positive. In otherwise healthy children, it is not an indication for any intervention. Other lab findings in UTI include blood leukocytosis, neutrophilia, elevated ESR and C-reactive protein, increased serum procalcitonin, and positive blood culture in urosepsis. Now, new tests for UTI include urinary biomarkers such as interleukin-6, neutrophil gelatinase associated lipocalin, and real-time PCR to identify uropathogens. Next, I will discuss treatment of childhood UTI. Most children are treated at home with oral fluids and antibiotics. However, some require hospital admission for IV hydration and antibiotics. These include children who are dehydrated, who are vomiting, who are unable to drink, who are 1 month of age or younger, who have complicated infection. Those children in whom urosepsis is a possibility. Children with significant renal tract anomalies or who are not responding to oral therapy. Now, duration of treatment of acute cystitis is 3 to 5 days, and the antibiotics required are cefixime, trimethoprim sulfamethoxazole, nitrofurantoin, or amoxicillin clavulanate. Pyelonephritis is treated for 7 to 14 days, and the antibiotics required are ceftriaxone, cefotaxime, ampicillin plus gentamicin, imipenem, or ceftazidime. However, oral antibiotics for pyelonephritis include cefixime, amoxicillin clavulanate, trimethoprim sulfamethoxazole, cefotaxime, cefprozil, cefuroxime, and ciprofloxacin for resistant organisms. Now, in some children with febrile UTI, a single intramuscular injection of ceftriaxone followed by oral cefixime is effective. And in children with renal or perirenal abscess or infection in obstructive urinary tract, surgical percutaneous drainage is required. Now, the prophylaxis and prevention of recurrent UTI. Recurrent UTI is labeled when there are 3 or more episodes of cystitis, or there are 2 or more episodes of UTI, including at least 1 episode of pyelonephritis. Now, antibiotic prophylaxis has risk of antibiotic resistance, so it is not indicated after first or second UTI in otherwise healthy children. It is beneficial in neuropathic bladder, urinary tract stasis and obstruction, or reflux and calculi. Drugs used for prophylaxis in recurrent UTI include trimethoprim sulfamethoxazole, nitrofurantoin, amoxicillin, and cephalexin in 30% of the normal therapeutic dose once a day. Now, other prophylactic measures for recurrent UTI include circumcision in males, education for adequate genital hygiene such as wiping perineum from front to back in girls, then appropriate toilet training and active management of constipation to prevent functional bladder bowel dysfunction. Now, cranberry juice and probiotics have not proved beneficial in preventing recurrent UTI in children. Okay friends, thanks for watching. Please like, share, comment and subscribe to my YouTube channel for more informative health related videos.